Welcome to tonight's flu vaccination update, another in the Twilight online series. I'm Michael Johnston, GP from North Sydney, and I'm the facilitator for this webinar that has been developed with the help of New South Wales Health. And tonight I'm very lucky to be joined by Dr. Vicky Shepherd from New South Wales Health and a fellow GP, Dr. Tim Senior. Just before we start, I'd like to make an acknowledgement to country where we recognise the traditional owners of the land and sea on which we live and work. Now I'd like to introduce our expert resource people tonight. Dr. Vicky Shepherd, many of you would know, is a public health physician who's been working with New South Wales Health since 1999. Vicky's current role is Director, Communicable Diseases Branch, Health Protection, New South Wales. And this role includes overseeing surveillance of notifiable diseases in New South Wales, coordinating communicable disease control activities, oversight of immunisation programs, which is relevant tonight, and that includes delivery of the school-based adolescent vaccination program, as well as representing New South Wales on the Communicable Disease Network Australia. Now, previously, Vicky managed health protection services in the Nepean Blue Mountains and Western Sydney local health districts up until 2013. Welcome to the program, Vicky.
Oh, thanks, Michael. Good to be here again.
And our other expert resource person is Dr. Tim Senior, and Tim is a GP from the Tharawal Aboriginal Corporation in southwest Sydney. Tim originally trained in the UK and currently is an RACGP medical advisor with the National Faculty of Aboriginal and Torres Strait Islander Health, of which I'm also a member. And Tim is a senior lecturer in general practice and Indigenous health at the University of Western Sydney and a very popular medical educator. Welcome to the program, Tim.
Thank you very much. It's a pleasure to be here.
Now, just to refresh and have a look at our learning outcomes for this evening's program. Hopefully by the end of this activity, we should be able to utilise the new flu vaccines and the accompanying guidelines for this year. Importantly, identify patients in high-risk groups and target them for flu vaccination. Implement evidence-based management of influenza and reduce morbidity and mortality in aged care facility outbreaks. Vicky, we can only, I guess, compile statistics on influenza from cases that are reported.
Yeah, that's right, Michael. And yeah, this is a bit of a representation. The flu notifications we get are just the tip of the iceberg. I have another analogy I like to use about flu. It's the blind men and the elephant. Mm-hmm. Because we can't get an exact handle on the impact of flu on health, we use a number of ways to look at it. And so the slides, some of the slides we've put together in the beginning of the presentation show some of the ways we measure flu routinely. And so I'd like to kind of go through those and explain to GPs Vicky. How we monitor flu.
Yeah. Well, last year, Vicky, we were talking off air. I had a number of patients with Influenza B last year, and that seemed unusual to me. Maybe this graph could explain it.
Yeah, so this is a graph of influenza notifications, so that's swab positive cases, and it's from 2011 right through last year's season to the beginning of this year, and the red line is influenza A. So the number of diagnoses per 100 samples that are sent to laboratories across New South Wales, and the blue line is Influenza B. So right up there we can see that 2015 was an unusual season because there was about double the number of Influenza B than Influenza A, and that hasn't happened since for over a decade. So it was an unusual season. And the other thing that was unusual was that we started off with the vaccine B strain that was in the trivalent vaccine, the Yamagata lineage, and that got overtaken during the season by the non-vaccine strain. So we had two B strains circulating, very unusual.
I guess that gives us an indication that the flu vaccine is effective because the B strain that was covered in the vaccine was certainly nullified.
Yes, it was outcompeted.
Yeah.
And I guess the other thing, looking at this over those previous years, we've back in 2011 and 2013, the H1N1, the pandemic strain, was predominant. Yeah. And in 2012 and 2014, the H3N2 strains were predominant. And we'll talk about that a little further when we look at the impact of those seasons on health.
Tim, you've got a fairly special patient population. Does this graph reflect what you find in your clinical practice?
Yeah, I think one of the interesting things that I learned in this is about the different population groups that the different influenza virus strains affect. So, so some years, so last year there were lots of, or I think coming through the, we'll be talking about this, more adults, and then some strains affect more older people, and some years children get affected. And so I think that's one of the very interesting things that we see. The clinical symptoms, obviously, and the effect of that are often relatively similar, but sometimes the severity can be different that we see as well.
Yeah. Vicky, this graph shows us the spread of influenza in New South Wales according to the age groups. Would you like to talk to this slide?
Yeah, that's right, Michael. So it's the same 5-year period, looking at 5 influenza seasons, and this time we're looking at which age groups were notified with influenza. So this is the same laboratory tests that were positive on the previous slide, but looking at it by age group rather than by type. So in 2011, the black indicates that young adults were relatively heavily affected, as well as kids 5 to 14, and that was an H1N1 season. So we know that young adults are particularly susceptible to that strain of flu. Then in the 2 years, 2012 and 2014, when H3N2 predominated, the very young 0 to 4s were susceptible, and that's perhaps because we hadn't seen that strain for a while, so that age group wouldn't have had no immunity to it. And then last year, we saw the 5 to 14-year-olds. So again, those B strains were not familiar to school-age children, and that's obviously a good breeding ground for spreading flu once a new strain comes in.
Yeah. This next slide, Vicky, I guess begs the question, where do you get your data from? Is it from general practices, emergency departments, combination?
Well, as I said, with the blind men and the elephant, we use as many sources as we can. So this one here is from a sentinel surveillance system that we have in GP practices in a few metropolitan local health district areas. And that takes information straight out of the software about patients presenting with influenza-like illness. And in these next few graphs, the most recent year, 2015, is always shown in dark, in a heavy black line, and the previous years in different colours. So right away we can see that 2015 was a big year for presentations to general practice. There was 2 peaks to the season, and that was partly the early A peak and then a later B peak. It was a relatively late season, compared to 2012, for example, where that dotted darker blue line was, it was early July, whereas last year didn't peak until September.
Yeah.
And, we do find this GP surveillance actually finds the beginning of the season a bit earlier than some of our other sources. So.
Yeah. And of course, a number of our patients who get influenza present to emergency departments with pneumonia or severe primary viral illness, don't they? So could you talk us through this slide?
Yeah, so these next couple of slides, these come from our emergency department surveillance, which is in 59 emergency departments across the state, so fairly comprehensive. And again, the top graph here is just presentations for what we call influenza-like illness. So it's, not confirmed flu, but it's a good measure. And again, you can see that 2015 was a pretty big year, similar to 2014, which was also a big year. And with that double peak, we can see that also with emergency department presentations and a second peak with influenza B. And, we call the start of the season last week in June, peaking mid to late August and then declining back to normal levels late September.
Tim, I guess pneumonia is the major complication of influenza we're trying to prevent. Are there other complications that come to mind?
Yeah, I mean, I think so some of it is just the feeling awful in the time off work. Many of the patients that I see have chronic diseases, and so people with other chronic diseases are often more susceptible, and so pneumonia would be one of the main ones, but it can also sort of do things like make people's cardiac function or renal function deteriorate as well. Because they have less capacity for adjusting and recovery, and I think then as well, sort of sometimes there's particular strains where young adults or children are particularly vulnerable as well, and so it can be important to know what to look out for depending on the strains that we're expecting, I think.
Yeah. So Vicky, how did the admissions to the critical care wards compare last year, say, to the previous 5 years?
Okay, so these are the next two slides, and again, this is different ways to look at a flu season. So again, in the top graph, 2015 is the heavy black line, and obviously there's fewer patients involved that do present with influenza-like illness and then get admitted to critical care. But you can see that in most parts, 2015 is reaching the peaks of that seen in other years. So, yeah, overall it was a big year as far as numbers of diagnosed cases go, and also having quite high numbers of admissions. The second graph is another kind of sentinel surveillance. So this is, we call it FluCan. It's part of a national program, and this is in 3 hospitals in New South Wales: Westmead, Children's Hospital Westmead, and John Hunter. And it's about confirmed influenza cases in those hospitals. So there's a few things we can see here, but the bright green is confirmed influenza B. So in fact, the majority of confirmed influenza cases in those hospitals were due to influenza B last year. And then there was a fair smattering of the red, which is the H3N2 causing hospitalisation.
Right. So a lot of things the same with previous years, but a few things different. Could I get you maybe to summarise what happened last year?
Yeah. So last year the season started late June and peaked in late August, which is late compared to some other years. High levels in the community and high emergency department activity. Overall, there was less hospitalisation than in 2014 when the H3N2 predominated, but still, as we can see, quite a lot of hospitalisation. And influenza B was twice as many notifications as for influenza A. So we had all 4 flu strains. The B matched the vaccine well, but the predominant B strain was only in the quadrivalent vaccine.
Hence, a few of my patients who had the flu vaccine, the trivalent free one, still got influenza B, and they're unlucky.
Yes, yes, and at the beginning of the season, we didn't predict that would happen because we've never seen the 2 B strains circulating, so that was something we learnt from, and I think that now comes into our approach to vaccination this year.
A question without notice, Vicky. I'm obviously interested in pregnant women. Do you have any figures on the incidence of influenza in pregnant women?
Well, again, we don't have exact incidence, but the data that we gathered from the pandemic when we did obviously study severe influenza in great detail. From the top of my head, Michael, I think the risk for hospitalisation with flu for pregnant women was about 4 times or 5 times that of non-pregnant women aged in that same age group, 15 to 44, during that period. So, yes, pregnant women are particularly susceptible to having severe flu if they catch flu.
So all the more reason to vaccinate.
Yes.
So that was last year. Let's see if we can have a look at what maybe we're in store for this year.
So again, there's a few ways we try to get a handle on this. So this graph here is from the map is from the World Health Organization, and it's showing the most recent reports from the Northern Hemisphere of what strains of flu are circulating. So the pale blue is our old friend H1N1. And in most parts of the Northern Hemisphere, that's the predominant strain. And there is a little bit of the H3N2, which is the kind of the tealy blue colour, and the same strain we used to have here. We've had here in those other severe seasons, 2014 and 2012. And then a fair whack of Influenza B, which is the kind of the brownish colour there.
Yeah, okay. And I guess we're in a fortunate position. We can see what's happened to the Northern Hemisphere winter and hopefully match our vaccine with the strains that we're predicting to come to Australia in our winter.
That's right. Well, in fact, the decision about the Southern Hemisphere vaccine was actually made way back in September 2015, and that has to happen in order to get manufacturing ready to get us vaccine now. So the vaccine's predetermined, but we can, by observing the Northern Hemisphere flu season, we can observe what strains of flu are circulating, and we now feel quite confident that the strains that are in our vaccine this year match what has been circulating in the Northern Hemisphere.
Vicky, Dr. Jarman asks, is flu common between seasons?
Well, I think our next slide kind of shows that.
Okay.
So this is a graph of interseasonal flu in New South Wales. So it's just looking at the period from the beginning of January up to Easter, and we've got different years plotted there from 2012 up to 2016 in red. And these are the percentage of positive flu samples that come back. So yes, flu is in fact still relatively common, and we get this year the H1N1 is predominating, and we've in the month of February we've had something like over 10,000 tests, and so about 4 to 5 to 6% of those have been positive.
Right. Yeah.
So.
Yeah. That's interesting, isn't it? Because I do a fair bit of travel medicine as well, and a number of patients who are travelling to the Northern Hemisphere ask me whether it's worthwhile having last year's flu vaccine to protect them against this year's Northern Hemisphere winter. And assuming that the vaccine's still in date, of course, would there be some benefit to giving that?
Yeah, well, the previous slide that we can see from the World Health Organization, this is available on public websites, so you can always go and find out what is circulating.
Yes.
And yes, so if they had the 2015 quadrivalent vaccine, they would be covered against all the strains that are circulating in the Northern Hemisphere, or if they'd had the trivalent, they would be well covered against the H1N1 and one of the Bs. Last year's 2015 vaccine wouldn't have given them good protection against the H3N2 because the strain had drifted a bit.
Right. Yeah.
But still, there is some benefit in having that vaccine.
Yeah. Did you want to talk about the New South Wales Health's 2016 winter flu campaign at this point?
Well, yes. Certainly, we'll be, and we'll kind of cover that as we come through some of the other slides. So we're hoping to increase the coverage in some of the groups that haven't been reached in the past, particularly Aboriginal people and people with chronic conditions. And we'll get on to the new vaccines that are available, and I think that'll be good news for many patients that we have a quadrivalent vaccine available for us this year.
And GPs can access weekly reports, can't they, on what's happening in 2016?
Well, that's right. So the reports the graphs that we've just talked about, which is looking at flu activity from a range of perspectives and reporting which strains are predominant, we produce those monthly in the out of season, and from May we produce those weekly. So these are available on the website you can see here, and really encourage GPs to look there and get this information to inform them and their patients.
Great. I think Penny's going to put that actual website up for our participants to access, which is great.
I'd just add to that as well from one of the earlier slides you were talking about, Vicky, often GPs are seeing the early start of the flu season just before it's being reported in public health, so it might be a nice site to keep an eye on just to see if what they're seeing in practice is starting to be reported by other GPs as well.
Yeah, that's right. Tim, our data does show that the peak starts in general practice before it even reaches hospitals.
Yeah. So, Vicky, what's in store for us, and including our patients this year? And I guess it's a good reminder that all GPs should be vaccinated against the flu as well.
Yes. Yeah, well,
Absolutely.
yeah, I don't know if Tim would like to talk about the new vaccines that are coming on.
So, I mean, I'm not sure I have very much to add. You can see on the slide there, that's the quadrivalent vaccine, and you can see that there are slightly different strains in this year's vaccine compared to last one. So at the top there, the A H1N1 vaccine is the same as last year, and the B vaccine at the bottom there is unchanged from 2015, but the middle two, the B Brisbane version is new in the quadrivalent vaccine, and the A H3N2 is different from last year. So, I think I'd be right in saying that we're optimistic that the vaccine will have good coverage for what we're expecting, and so should provide good protection. The National Immunisation Programme is supplying quadrivalent vaccines, and we'll show you the two versions of those available under the National Immunisation Programme. Trivalent vaccines are available privately, and so you can prescribe those. But the quadrivalent vaccine probably provides better protection and is the one recommended, certainly, and is the one available under the National Immunisation Programme.
Tim, for patients who have to pay for their flu vaccine, how do you approach the cost-benefit analysis? Or how do you sort of win patients over? They may be at risk of complications of influenza or spreading influenza, but not qualify for a free vaccine. How do you approach those patients?
Yeah, I think that's a really good question, and I think everyone will have their own ways of discussing that. I think the most important things are that it does protect you, particularly from severe versions of the flu, and it does protect from transmission of the flu, and so the main benefits are, if you want to be at work and can't afford time off sick, which most people say, then it'll be beneficial for that. Or if they want to prevent spreading it to other people or spreading it to themselves, then it's also good for that. So I think the benefits of that, it's a small price to pay for actually being able to stay at work, being able to stay looking after family, doing the tasks that you need to do in your day-to-day life without being knocked flat by flu. And I think that's the approach I would take.
So is it fair to say, Tim, it's a sort of, I guess, a two-level approach, personal protection, but also for the greater good as well, not spreading it amongst others who might be vulnerable to complications?
Absolutely, and I think that's right, and I think you can probably pick which patients will respond to which particular message as well. Some time off work will be the clincher for them. Others, protection of family will be important.
Yeah, great. Well, let's have a look at the two brands that are available, Tim or Vicky.
Yeah, well, if I could start off. So I think this is pretty important and important news for GPs to be aware of this. So these are new products completely for general practice, as I understand. So the pink and blue package is what's being provided under the National Immunisation Program for children under 3. So that's Flu Quadri Junior. And then the green and yellow packaging is what's supplied for all other people 3 years and older on the National Immunisation Program. That's the Fluorix. So yeah, new items in the fridge to pick from.
Tim, who would you recommend the Flu Quadri Junior for?
So those would be for only for children. With some of the previous vaccines, you've been able to give a half dose of the adult vaccine. That's not the case for this, though. So the adult Fluorix Tetra isn't licensed for children under 3, and the Flu Quadri is licensed for children over 6 months and under 35 months. And so essentially, the indications are anyone that you want to protect their health for, and I think there are particular recommendations which we're coming on to on the next slide of those who are particularly in the National Immunisation Programme, and that includes children with chronic diseases in children and Aboriginal and Torres Strait Islander children.
Mm.
And I think those are important children to target.
So, Vicky, with the flu quadri junior, is it 1 or 2 doses for those children?
In the first year that they're vaccinated, any child under 10 should get 2 doses. So children under 3 would get 2 doses of flu quadri junior. Children from 3 to 10 would get 2 doses of Fluarix tetra, or 3 to 9, to be more precise. And then once they've had 2 doses in one season, then the following year they just need 1.
Right, okay. And so, Tim, I guess this leads on to who should be immunised.
Yep, so as you can see on the slide in front of you, these are the people where they recommend immunisation. And so any person older than 6 months can have the flu vaccine. And then under the National Immunisation Programme, those are the people at risk, so adults aged 65 or over. Aboriginal and Torres Strait Islander people, so children under 5 and any Aboriginal people over 15. Particularly pregnant women, and Michael talked about the importance of that, and one of the other important things is that does provide some protection for the newborn baby because they're unable to have the vaccine up until 6 months, and they get some passive protection, and flu can also cause problems with the pregnancy, so it's a particularly important group to target. And then people with chronic diseases, which is that list encompasses pretty much most chronic diseases. You'll see the third dot point, other chronic illnesses requiring regular medical follow-up or hospitalisation, which would be most chronic diseases that we would be seeing that require some form of treatment. So those are the people covered under the National Immunisation Programme.
I seem to remember a definition from a couple of years ago where any chronic condition may be exacerbated by influenza. Would that still hold true, Vicky?
Yes,
Yeah.
well that's right,
Yeah.
and that's the reason that there's free vaccine for all these groups.
Yeah, okay. And Tim, you've already mentioned this, but I think it's probably so important it's worth just going over again.
Yeah, and perhaps if I could jump in here. So this is the product that the State Vaccine Centre will provide to general practice for children under 3. There's a fairly limited number of doses. I mean, there's thousands of doses available, but it's very important that we use it for this group, the eligible group, and use it for children under 3. So once a child is 3 years of age, they can be given that the Fluarix product.
Yeah. Dr. Coco asks, Vicky, when will the vaccine be available?
Well, we've received vaccine this week and we've started distributing to general practice, so we've prioritised general practice and Aboriginal medical services. So if you have an order in with the State Vaccine Centre, that should be coming to you starting this week, and if not this week, next week or the week after.
Yep, great. All right. And Tim, are there other groups who may not be covered under the NIP, National Immunisation Programme, who we would sort of feel strongly about vaccinating against influenza?
Yes, so there's you can see the list on the screen here. Healthcare workers are an obvious one because by definition people with flu are going to be coming and seeing people in healthcare services, including yourselves and your practice staff, and so immunisation is going to be really important in terms of keeping them at work. We'll also be mentioning the importance of people in aged care residential facilities as well. People in the poultry or pork industry is an interesting one because of the possibility of risk with pandemic flu and the crossover into swine flu or bird flu with those in contact with people with other flu strains. Now, those may well be organised by the industries themselves, but people will come in with you asking. It's important to know, and some practices will be in areas where that's a major part of what they do. There'll be a poultry or pork industry in their area, so that's worth being aware of. Obese people is on the list because in some of the outbreaks in previous years, people have been, obesity has been one of the common medical conditions listed among people who have been admitted to hospital, and so so it may be that they have slightly worse outcomes than other people, which is why they are in this list, but they're not covered in the National Immunisation Programme. And then children with Down syndrome as well have a particular risk.
Yeah.
Tim, so they're another important group.
Tim, a relatively large population, although fortunately it's decreasing in prevalence, and that is people who smoke. Is there any sort of evidence that they should be vaccinated against influenza?
It's a good question. Gut instincts would tell me yes, that they should be that they should be given the flu vaccine. Certainly, I'll be offering it to patients of mine that smoke. I think smokers who are aged certainly probably over 45 and certainly aged over 50 or 55 are quite likely to have COPD, and so they would come in with the chronic disease provisions. But smoking itself wouldn't be one of the chronic disease, so technically if that's all they have, they probably don't come under the National Immunisation Programme, but certainly I'd be recommending that smokers have immunisation, though I'm not aware those statistics that we presented earlier on didn't classify people as to whether they were smokers or not.
Yes, and that's right, Tim. While I think we'd all think it was a good idea, and the studies that have been done haven't picked smokers as being a particularly susceptible group. So
yeah. Quite a few questions on the pregnancy issue here, Vicky. Dr. Daly asks, presumably the vaccine is safe in pregnancy. Are there any particular trimesters that it should be given in or avoided?
No, RANZCOG, the Royal Australian New Zealand College of Obstetrics and Gynecologists, recommended that it is safe and can be given in any trimester, and it's and their estimate that they publish is that by vaccinating 5 women, you prevent 1 admission of a child or a woman. So it's highly cost effective to vaccinate.
Yeah, that's actually numbers needed to treat quite low, isn't it? It's amazing. Yeah.
And
that's very good.
And as far as, you know, it's really about the availability of the vaccine. So with whooping cough vaccine, we recommend 28 weeks each pregnancy, but we've got this gap between January and March where we may not have seasonal flu vaccine, so it's really opportunistic with pregnancy. That's vaccinate, you know, whenever the pregnant woman comes in, you've got the vaccine, offer it.
Yeah, that's great. Thanks, Vicky. Hopefully that answers your questions, Dr. Daly and Dr. Karupal. Now, can we vaccinate, Tim, this is one for you, can we vaccinate any child 6 months or more without any risk factors?
Essentially, yes. So that we'll come to the contraindications in one of the slides coming up shortly. But essentially, yes, the main contraindication is children who are or people who are allergic to the flu vaccine and with a proper allergic reaction. And we'll talk about that in a minute.
And Vicky, I guess the spacing between the 2 doses for children under the age of 10.
Yes, if I could just go back to that earlier question about can we vaccinate any child over 6 months? Of course we can, but that vaccine Flu Quadri Junior is supplied on that National Immunisation Program, so other children would need if they didn't have an indication of a chronic medical condition or aspirin therapy, they would need it on a private script, but there's certainly it's certainly recommended. So the spacing of the doses is at least 28 days apart in that first season when you need 2 doses.
Okay. And Tim, Dr. Alkin and a few others have argued that Down syndrome could be classed as a chronic condition.
I think I would be making the same argument, actually. I think that would be fair comment.
I usually find a spare free one for my Down syndrome patients, I must admit.
I won't tell.
Vicky, a tricky one for you. My patient is going overseas, so she had a trivalent vaccine. She's 72. Should she have the quadrivalent vaccine when she returns?
Well, you know, that's always a difficult question. I think we can probably watch the flu season.
Mm-hmm.
So you'll know what was in the trivalent vaccine from the earlier slide, which strains of the flu.
Yeah.
If it's a 2016 trivalent, then she'll have good coverage against, if we have H3N2, good coverage against H1N1, and good coverage against one of the B strains. So if she comes back and we're not having too much of a B season, then it's probably not necessary.
Okay. Yeah. Good point. Tim, just to finish off the sort of the questions, what about a baby under the age of 6 months? Not recommended?
No, it's not recommended, and I think it's not effective at that age, and up to 6 months. It's one of the reasons for vaccinating pregnant women is that for those first 6 months they're protected by passive immunity from the mother.
Yeah.
Yes,
okay.
and it's not actually licensed for children under 6 months.
Okay. Side effects we know about. There's no live component to the vaccine, so side effects are minimal, and we're going to talk about the myths, I think, of flu vaccine a little bit later in the program. So, all right, well, let's get some audience interaction here, and we'll run a poll, and the poll questions asks, what percentage of your practice staff, including yourself, get vaccinated against influenza each year? So I'll ask Penny just to open up the poll, and we'll get your answers. So you've got the choice of less than 20%, between 20 and 50%, 50 to 80%, greater than 80%, or if you're not sure, if you're not talking to your practice staff this week, there's all those options there. Okay, so we'll leave it open for another couple of seconds and another 10 seconds. So we're finding out what the percentage of your practice staff, including yourself, get vaccinated against influenza each year. Okay, we might close the poll now. Thanks for that, Penny. Okay, and the results. Okay, let's have a look there. Tim, can you comment on the results of the polls there for us?
Yeah, so 39% of you said that more than 80% of your practice staff, and another 25% said between 50 and 80%. So that's excellent. It's quite, the numbers are quite low. There aren't many of you where there are quite a small percentage. There's a reasonable number where of people are unsure about whether practice staff are being vaccinated, and I wonder if what we're seeing there is that where you're providing it or you're recommending it and you're knowing that staff are doing it, you're getting a high take-up, and otherwise you don't necessarily have any reason to know. It's an interesting question to ask because it'll be because it's interesting to have a think about our own practices and what we're doing for ourselves and our own practice staff, and whether that influences what we're advising patients or other recommended groups to do.
Great. While you're on a roll, Tim, the next slide shows that Aboriginal and Torres Strait Islander patients, of course, are at greater risk of complications from influenza, aren't they? Can you put that into something?
Yes, absolutely. Yeah. So this is really interesting. What we see here on those dotted lines on the slide here, we see children 0 to 4 having quite a peak, and we see Indigenous people greater than 50 years with quite a peak as well. And it is also higher in age 5 to 49, but particularly high peaks in children and in older adults, and much higher than the non-Indigenous population as well. So we're seeing a particular population at risk of being hospitalised as a result of influenza.
Great. Anything to add to that, Vicky?
No, well, and this kind of data is what's led to the program of free vaccination for Aboriginal people. So irrespective of any underlying condition. According to the National Immunisation Program, there's a gap between 5 and 15 years where Aboriginal people aren't eligible for free vaccine, but all other age groups of Aboriginal people over 6 months are eligible for free vaccine, and we'd really encourage actively finding and vaccinating Aboriginal people.
Tim, how do you incorporate... Go on.
I was just going to say the key step in practice is actually to identify our Aboriginal and Torres Strait Islander people, and this is one of the most important reasons for doing so, I think, is that the immunisation requirements are different, and to prevent this level of hospitalisation. So it actually, identifying our Aboriginal and Torres Strait Islander patients affects clinical decisions made in our consultations. Once people have been identified by asking the question, and then it's in the medical records coded appropriately, you can then do recalls, so calling people in and offering them a flu vaccine rather than just waiting for them to come into the practice. Those of you involved in primary health networks or in Aboriginal medical services may also think about outreach and going out to community events to actively vaccinate. But in practice, certainly identifying and then recalling people in is a great way of reducing those hospitalisations.
I guess this is probably a good time to introduce the idea of the pneumococcal or pneumovax vaccine at the same time, Tim.
I think that's right, because that avoids you calling in 2 weeks later for an update to the pneumococcal vaccination. It's the same group of people. The important thing about pneumococcal is it's 5 years apart, and for the general population, there's usually now just one pneumococcal vaccine recommended, but for Aboriginal and Torres Strait Islander people, they recommend having a pneumococcal vaccine at age 50 and then another one, a second one 5 years later, so 2 5 years apart. And so if you're recalling people for influenza, check whether they've had up to date on the pneumococcal vaccine as well, because that can be given at the same time.
Great. So Vicky, we've heard about all the people who should be vaccinated. Who are the people who shouldn't be vaccinated?
Well, very few where it's contraindicated. Of course, if they've had anaphylaxis to flu or the components of the flu vaccine. And then, as we've already talked about, children under 6 months, the effectiveness hasn't been demonstrated. So yeah, I think egg allergy, severe egg allergy, anaphylaxis to egg is a contraindication, but some people, they might be healthcare workers who have severe egg allergy, may need to be vaccinated. So we do have a service in New South Wales, and I think we mentioned at the last webinar, the NSW, the New South Wales Influenza Specialist Service, and that's a 1-800 number, and that's accessible to all GPs across New South Wales. So if there's a problem patient that you really need to get vaccinated and you're not sure about the contraindication, they can help you, and they can vaccinate under supervision for egg allergy people if needed.
Right. Hopefully that answers your question, Dr. Biswar. Thanks for that. Yeah, so egg allergy, and I guess I always impress upon patients that there's no way they can catch influenza from the vaccine because there's no live particles in it. Tim, we all have those patients who say, I'm not having the flu vaccine because I got the flu from the vaccine last year. How do you approach that sort of comment from a patient who should be vaccinated?
Yeah, that seems so common, and I think so one of the things that I reiterate is that people can get flu-like illnesses from other viruses that are unlikely to have been the flu, and that the flu vaccine actually protects against the worst of it, that flu that really knocks you on your back and puts you in hospital, and so that it's protecting against that, but people may still get fevers and sweats and feel a bit grotty as a result of other viruses that circulate in the community. I think the other important thing is that it is it's not a live vaccine, and so it stimulates the body's immunity without actually giving people flu. Sometimes you can use the fact that if people do get a mild reaction to the vaccine, that's a sign that it's working, that they are mounting an immune response to it. So so that might be a way forward. And then those conversations we were talking about earlier about how it's not just about protecting yourself, it also protects transmission to other people around you.
Tim and Vicky, Dr. Khoury asks some very good questions. He has an issue with young healthy people being immunised and never developing natural immunity to flu. Any thoughts on natural immunity versus immunity from vaccination?
There is no difference. So the immunity you develop from the vaccine is the same as you get from the vaccine, from infection in the vaccine. So
as opposed,
and I think that the nature of I think the nature of flu is different in that you get this antigenic drift each year, and so you do get the different strains coming down, and so you're, which is why the flu vaccine needs to be given every year, because you're constantly faced with a flu influenza virus that has different antigens, and so people don't tend to have develop a sort of a natural long-lasting immunity because it's constantly changing.
Yeah, right. All right. So, Vicky, how are we going with getting our vaccinations to the people who are at high risk and should be vaccinated?
Well, thanks, Michael. We'd like to do a little better. This is the data from the New South Wales Health Survey in 2015. So it's a survey of 17,000 New South Wales residents every year. And the purple colour is people 65 and over, and the red colour is those under 65. So overall, we can see we do better at vaccinating people who are over 65 than those under. So the bottom two lines are the whole population. The next is the Aboriginal people, and we can see that we do a bit better in vaccinating younger Aboriginal people than we do for vaccinating the general younger population. But the older Aboriginal people, we're not doing as well as we are for the rest of the population.
Yeah.
And then we just picked out a few of the risk groups there, people with asthma, diabetes and obesity. And overall, we do better vaccinating them than we do the general population, but it's still not reaching, particularly those under 65 where we could get vaccinated a lot more people. And then pregnant women, only 24% reported being vaccinated last year. Yeah. So that's a pity, because we like to vaccinate every pregnant woman every year.
Yeah. So I guess, Tim, it begs the question, how can we improve the rates of vaccination of these higher risk patients? Are there sort of practice systems that we can use to increase our capture of these patients?
Yeah, and I think that's the way to get these figures up, is that if we're just waiting for people to come in and then relying on our memory to vaccinate people, that's not particularly systematic. And the more systematic we're able to be in practice about doing this, then the more likely we are to vaccinate appropriately. And so that means identifying our patients in our patient databases and calling people in either by phone call or letter or SMS, and having systems perhaps where we identify people in the waiting room presenting for other reasons, to make a note of who we need to discuss vaccination with. And it'll be up to the ways of doing that will be different for each practice, and for some practices it may be something that practice nurses are in an ideal position to do. For others it may be practice managers. In others it'll be a particular GP or even a GP or medical student project. They make very nice little projects for doing that. But having those systems in practice that do things systematically rather than on an ad hoc basis, I think, is one of the key ways of getting those statistics up and keeping people out of hospital.
Yeah, great. I think we've already covered most of these points. Tim, maybe if you can just pick the eyes out of this one for us.
Yeah, so we saw in the previous graph targeting younger risk patients and pregnant women is got to be important. We've mentioned pregnant women quite a few times. Sometimes the patients who struggle to access our services either for reasons of distance or transport or cost, we need to think a little bit differently about reaching them, and whether that's offering specific clinics, maybe at different times, or maybe that are easier to reach, or maybe that are run on the bulk billing rather than paid for service. That'll be down to each service, but sometimes we need to think about those sorts of things. Overcrowded housing, interesting one. We certainly know, I regularly meet patients where that's a particular problem, but we actually don't have a way of coding that in the records that we can search, and so that's worth keeping front of mind, that to wonder about how many people are at home, it's actually very difficult to do a recall on that. Perhaps an imaginative way of using the addresses in the database or something, and then remembering to have the conversation despite all our other time pressures with people. And we've talked a little bit about their patient misconceptions that there often are. Things that help that conversation in the surgery can be things like videos or DVDs on TV screens in the surgery, posters up and leaflets in the surgery, and having practice nurses able to discuss it as well, and all of those can promote the uptake of vaccines because people start thinking about it as soon as they enter the surgery doors.
So Tim, I guess this leads on to managing flu cases. How do we manage a suspected patient with flu-like symptoms?
Yeah, and this is I'm sure this is something people see a lot of, and I think I saw a comment earlier on that I also agree with, that we're not often identifying the particular strain of flu, or we're making clinical diagnoses most of the time rather than a laboratory confirmed diagnosis. The management's pretty simple in terms of symptomatic management of rest and plenty of fluids, and children not being given aspirin to treat their fevers. Paracetamol or ibuprofen is entirely appropriate. And remembering that antibiotics aren't effective for viral infections, and having ways of taking our antibiotic stewardship seriously, so that we're able to have conversations that reassure people that antibiotics won't get them better any quicker and will only give them side effects. It's interesting to think about when we swab people to make the diagnosis of flu, and I was thinking I do this quite infrequently. It's unusual that I find the need to do that, and it may be necessary in times where there's some where establishing the diagnosis is uncertain but going to be important. So perhaps in a child where it may be important to differentiate between influenza or respiratory syncytial virus. Perhaps in older people where you're wanting to differentiate between influenza or some other cause for their symptoms. And sometimes it may be patient preference, where they say, look, I'd be really keen to know what it is I've got and what implications of that are for my work. And sometimes it might be important in determining prognosis, or whether someone's going to be likely to need antivirals to keep them out of hospital. Antivirals are useful for those at high risk of complications to prevent hospitalisation, and starting them within 48 hours after the onset of symptoms gets the best outcome, and being on them for 5 days, and pregnancy is not a contraindication to that. And apart from being cautious about someone's renal function, they're not, they don't have too many side effects or interactions. Limiting the spread is important, so good hygiene, washing hands, making sure tissues get used and thrown away properly, and keeping people off work and isolating themselves when they do get infected, so it's not just spread to everyone else, and then keeping alert for complications that might occur in people, and so advising people what symptoms to look out for, and active follow-up.
Tim, a couple of points. The safety of the antivirals in pregnancy?
As far as I know, they are safe in pregnancy.
Yep.
Is that your understanding, Vicky? Yeah.
They're certainly recommended.
And what if a patient presents after 48 hours of onset of symptoms? Should they still have antivirals, or are they not indicated?
If I can jump in, they are still of some benefit. They're of more benefit if they're started early, but if it's a person who is at risk of hospitalisation or has been hospitalised, we'd certainly still use antivirals even later.
Yeah, great. Just a couple of questions to clear up here. What if a 20-year-old non-Aboriginal patient comes to the surgery and asks for the flu vaccine? I guess we sort of present the pros and cons and would probably vaccinate, wouldn't we?
Yes, well, I know many practices have private supply that's available there that they can sell. Otherwise, unfortunately, you might need to write a script, and then it's a matter of a discussion about whether they'd like the trivalent or the quadrivalent, how much they're going to be paying for it.
Yeah, okay.
And I think asking about their their work, and if they're a healthcare provider or one of the people in those groups, then it becomes even more important to be able to offer it, I think.
Yeah. And Tim, which antiviral in particular a number of our participants have asked?
Yeah, so Tamiflu I think is the usual one that's recommended.
Yeah. Okay. All right. Great. Vicky, what sort of resources and roles for GPs do we see in managing aged care facility patients?
Yes, well, this is a special circumstance of flu outbreaks. So the image to the right is some signage that we've produced and distributed to aged care facilities, and it's trying to help facilities identify and control outbreaks. But I think the GP comes into it in a few places. So the first thing is preparing for the season and vaccinating as many residents as possible, and also facilitating staff vaccination. And I know some organisations do fund the staff vaccination. But then it's also, if you're on, I think the Medical Advisory Council is working with your facility management to plan for an outbreak. So how it's going to be identified, who's going to do the swabbing, because this is a situation where swabbing is really important to identify whether or not this respiratory illness, febrile respiratory illness in the elderly is flu. Because sometimes it's another respiratory virus, and we have a completely different intervention. And then if flu is identified, then it's working with the facility how to isolate flu cases. We strongly recommend treating flu cases with Tamiflu, and then preventive therapy for other residents who are not yet ill. So again, using Tamiflu to prevent flu, and this can contribute greatly to preventing hospitalisation and death in the elderly.
And I guess there are some differences between the treatment dose and the prophylaxis dose for Tamiflu.
I don't know if Tim wants to talk about this.
And the influence of renal function too, Tim?
Tim?
I just need to unmute myself. Sorry. So the treatment dose of Tamiflu is 75 milligrams twice a day for 5 days, starting within 48 hours. Those patients with renal impairment need a reduced dose. Now those, the creatinine clearances, and the equations there, and you can often find an equation to put on your phone that will allow you to calculate that. And so 30 milligrams BD for 30 to 60 mils per minute, and under 30 mils per minute, 30 milligrams daily, so you can see reducing the dose. Prophylaxis is using Tamiflu for those who haven't got flu symptoms but have been exposed and need to be protected from gaining flu, and so that's 75 milligrams daily, not twice a day, for 10 days, so a longer course. And then those with renal impairment, 30 milligrams daily or 30 milligrams every other day for more profound renal impairment.
Great, thanks for that, Tim.
Someone was asking about Tamiflu on the PBS as well. And I think my understanding is, do you know, Vicky? I was just looking it up quickly.
Yes, I think it is, but we have a special arrangement for 8 aged care facilities in New South Wales. And so, in fact, we do have an emergency supply that we can get out to an aged care facilities because of this, 48-hour period where we really do want to get everyone started. It's quite a difficult thing to coordinate, which is why planning ahead of time is important. So, I really recommend that that planning happen.
And a number of our participants have also asked about the age for Tamiflu as well, as it can be given in children and younger patients.
Well, at the moment, under 1 year of age, it's only under specialist supervision. But over 1, yes, and there are this paediatric dosing available.
A couple of our participants have asked why aren't swabs being done more frequently? It's a good question.
Oh, is that in general practice or in aged care?
In general practice,
Well, in fact, over the years, we're getting more and more swabbing done. So there is a trend to increase swabbing, but I think as Tim was describing, if you're not using antiviral therapy, and in otherwise healthy adults, you probably won't use antivirals, and if they're not adults or at particular risk of complications, then you don't need to swab every case. If we know that flu is around and someone has the symptoms of flu, then it's not necessary. But as Tim described before, there are certain circumstances, people who are at risk of severe complications, those who you might be considering antivirals, or someone who wants to know what's infecting them, then certainly swabbing is
And do the pathology companies notify New South Wales Health when they get a positive result?
Absolutely. So that's those earlier graphs that we saw is all the notifications come into us.
Yeah, great. All right. And okay, just having a look at our questions here. Do we do a nasopharyngeal swab and oropharyngeal, or just nasopharyngeal?
So nasopharyngeal is preferable, or an infant's nasopharyngeal aspirate, but a nose and throat swab is also very useful.
Great. All right. Okay. Well, let's just revisit our learning outcomes. I think with this great discussion we've had with Tim and Vicky, we've now able to utilise the new flu vaccines and the accompanying guidelines for this year. We've identified very thoroughly the patients in the high risk groups and those who we should target for flu vaccination in particular. We've looked at some evidence-based management of influenza, and hopefully with the part of the aim is to reduce the morbidity and mortality in aged care facility outbreaks. So let's have a look at some of these resources for influenza. You can find them on that particular website, which Penny will also put up in the chat area. And
so there you'll find posters and brochures for your patients once they become available for the 2016 season, but we'll also distribute them to general practice as well.
Yes, all right. And I think we've answered a number of questions tonight. Thank you for those wonderful high-level questions that we've had from our participants tonight. I think it's been great. And thanks very much to Tim and to Vicky for their expert input into tonight's webinar. Thanks to the college for their support, and of course thanks to our participants for their very high level questions. And we've got a couple of other very interesting webinars coming up shortly as well. Travelling Safe, that's a travel medicine update on the 11th of May, and a shingles vaccination update in September as well. You can see the dates on the slide in front of you there. So thank you all again. Thanks very much, Tim. Thanks, Vicky, and look forward to seeing you at our next event. Thank you.
Thanks, Michael. Good night.
Thank you very much, everyone. Thank you, Michael. Thank you, Penny.